Perfect. Well, thank you, Terry, and thank you, Colleen, for that wonderful introduction. So because the recording stopped for a second, I'll just reintroduce myself quick. I'm Nicole Matson. I am an assistant professor for Marquette University within the College of Nursing. And I'm thrilled to be here today in this community because this community is doing such great work to help really advance and understand the way that opioids are impacting our community here in Waukesha County. So as Colleen had mentioned, I've worked with women and children my entire nursing career. And so this is an area that I'm passionate about. And I'm hoping to talk a little bit today about, my plan to talk today is about my research findings that I had in a study that I conducted just recently, where it was examining the ways in which women who have chosen to use medications for opioid use disorder for their recovery during pregnancy and that early parenting period, so that first year after having given birth, and how they're making that transition to a new parent while also managing their recovery process. So I just wanted to, let me forward my slides here. No conflicts of interest to disclose. And really, I'm hoping today that you can walk away with a little bit of an understanding of how the harm reduction principles have been embedded within perinatal opioid use disorder treatment care that we provide. And then also this ability to discuss ways in which mothers using medications for opioid use disorder are engaging in self-management in that first year of recovery after having a baby. So I wanted to start with a story. Through my research, I've had the opportunity to interview mothers who self-identify as being in recovery. And I've been able to interview them regarding their recovery journey, as well as their transition to motherhood. And one mother who I'm going to call Janelle for the purposes of our presentation today, shared with me two of her birth experiences. So while her births were 12 months apart, they were vastly different experiences. And so I'm going to use them to highlight some of the things that we see as challenges and opportunities for this population. So Janelle was using opioids when she found out she was pregnant. And she was about 2.5 months pregnant when she found out. And the moment she found out she was pregnant, she knew she needed to do something to get herself healthy because she wanted to do what was best for her and her baby. She went and found a doctor that would prescribe medications for opioid use disorder and began their program. She started working that program and took a lot of pride in the fact that she had only one time where her urine screen came back with the presence of drugs, and that was during her very first visit. So she worked the program, attended all of the different counseling, group therapy meetings, and all the scheduled appointments. When she was progressing in her pregnancy and getting to the point where she was ready to deliver, when she went into labor, the hospital that she had planned to deliver at was actually 45 minutes away. And when she went into labor, she didn't feel that she had enough time to drive all the way to that hospital. And so she went to a local or the closest hospital near her home. When she arrived, she was upfront about her substance use history and her current recovery work. And at that time, when she arrived at the hospital, she was already fairly far advanced in her labor progress. So she was 6 centimeters dilated and was already looking to have an epidural. She was told by the provider that was caring for her at that time that she could not have an epidural. And so she continued to labor and over time asked again for an epidural to see if she could have something for pain and was repeatedly told no, she could not get an epidural. She labored for 5 hours after getting to the hospital and pushed for 2 hours, all without receiving any pain medication. While she was laboring, she also missed her scheduled dose of her medications for her opioid use disorder. And when asked the provider if she could get a prescription for that and take that while she was laboring, the provider stated, "You've been getting your baby high enough. I'm not bringing him into the world high." After the birth of her son, she experienced some long periods of time where the child was separated from her. So the baby was taken to the nursery, or the nurses were watching over the baby. And she stated that that was one of the most traumatic pieces of her birthing experiences, hearing her baby cry when the baby was outside of her room. She also mentioned to me that one of the biggest things that she had known that you don't want to do for a baby that potentially is going to have some withdrawal symptoms is separate mom and baby. Eventually, over the course of her stay in the hospital, she ended up calling her doctor that she worked closely with at her recovery and treatment clinic. And that provider phoned in her medications. Her significant other ended up picking up those medications and bringing them to the hospital for her. After 5 days, when she was discharged and went home with her baby, she felt very hurt and frustrated and angry about her birthing experience, and felt that she had been left out of a lot of the decision-making processes there. So I wanted to introduce her first story and talk a little bit about that experience. So if you want to take a moment to just kind of think about, like, what is your first reaction or your reaction to hearing her story? But what I'd like you to do is maybe raise your hand through the reactions or the reactions tab, and let me know what were some of those challenges you heard that Janelle was experiencing. Otherwise, you can throw it in the chat. What were some of those challenges that you heard Janelle talk about? Yeah, thank you, Christine. Definitely judgment. There's a judgment by a couple individuals.
And Elizabeth has her hand raised, Nicole.
Oh. Go ahead, Elizabeth.
Hi, my name is Elizabeth Phelps. I am a house manager and FACS ambassador for Samad's House. FACS stands for Fentanyl Accidents Continue to Soar. The only time I was ever able to stay clean and sober was when I was pregnant with my children. But I have heard this story over and over and over again. There's a stigma to that needs to go away. If somebody dropped dirty at the very beginning when she found out she was pregnant, but managed to work an honest program, and pulled this forward, it's lack of care, it's lack of compassion, and they're not looking at the full story. They're just looking at what her previous diagnoses have been. Unfortunately, this is way too common, and it's something that needs to be addressed, or intercommunication or interpersonal communication between the doctors, between the providers, something like that. Because like I said, I've heard this way too often.
Yeah, the excellent points. And it is unfortunate that we hear this, that we're still hearing some of these stories. But yeah, in the chat, I'm seeing things like separation, prejudice, judgment, stigma, exactly. And so Janelle's story is just one of many. However, when I was doing interviews with women, I did hear components of her story in more than one. So this wasn't a one-off, this wasn't an outlier, unfortunately. So in the United States, we know that we're in the middle of this opioid epidemic, with rates of opioid use increasing in the general population, and that doesn't just disappear during pregnancy. So we see that it is increasing in the pregnant population as well. We know that the rate of opioid use in pregnancy is lower than that of the general population, but we do still see that the rate of births complicated by maternal opioid use quadrupled from 1999 until 2014. Opioid use disorder can involve prescribed opioids. It can involve medications for pain postoperatively, opioids that have been diverted, or illegal opioids such as heroin. And opioid use disorder during pregnancy can have negative consequences for both the mother and for the newborn. A complication that we hear a lot about is neonatal abstinence syndrome, or something that we're more frequently referring to now as neonatal opioid withdrawal syndrome. And the difference is really neonatal opioid withdrawal syndrome is it's more specifically defined to withdrawal from opioids. Neonatal abstinence syndrome is more of a general term that could be withdrawal from a host of different substances. So we know that this complication of neonatal abstinence syndrome is a complication that can occur in a newborn. And the reason that it occurs is because during pregnancy, if there is exposure to opioids in the maternal system, that fetus is being exposed as well. And then at the time of birth, there's this sudden stop or this cessation of that passive exposure of the opioids to the infant. And this can lead to some short-term as well as possible lifelong effects for that newborn. Nationally, we have seen that between 2010 and 2017, both the number of women with an opioid-related diagnosis at the time of delivery, as well as the number of babies being born with neonatal abstinence syndrome have increased. And then last April, the state of Wisconsin published their maternal mortality rate data for the years of 2016 to 2017. And in that data, we saw that 48% of pregnancy-associated deaths were related to an overdose. And that equated to 16 mothers that died from overdose here in Wisconsin during those years. So maternal substance use in pregnancy is one of the health issues where this harm reduction approach or those harm reduction principles has really been embraced. So organizations like the American College of Obstetrics and Gynecology, the Society of Maternal Fetal Medicine, as well as the American Society of Addiction Medicine have come together and created guidelines and recognized that focusing on harm reduction principles in pregnancy is going to be our best way of managing opioid use disorder in pregnancy. So with harm reduction, what we're focused on in harm reduction principles is not viewing addiction as a moral failing or a disease that requires abstinence being the only goal or complete abstinence being the only goal. Harm reduction allows us to use more of a pragmatic and compassionate way to minimize harm and the harmful consequences of the addictive behaviors, and really helps us to focus shift our focus from an absolute reduction of use to a reduction of harm from the use of those substances. And we see that in what's considered the gold standard for our treatment of women that have opioid use disorder during their pregnancy. The recommended treatment for opioid use disorder during pregnancy is a combination of medications along with cognitive and or behavioral therapy. Most frequently, the medications that are used are methadone or buprenorphine. And I know Terry sent out some handouts that go into detail about those medications. Both are opioids, and what they do is they help to reduce cravings and prevent an individual from going through withdrawal. So we have an opportunity to reach more pregnant individuals with what is considered this gold standard when there's been some research looking at how many women with opioid use disorder during their pregnancy are receiving this gold standard of treatment. And specifically looking at like Pennsylvania, and when looking at Medicaid individuals, only 56% of the women with this diagnosis were using medications for opioid use disorder. And a smaller amount of those women were receiving that cognitive or behavioral therapy in conjunction with the medications. So we have an opportunity to improve our outreach and hopefully reach more women during pregnancy. So you might be wondering why it is that complete abstinence would not be the recommended treatment. And so on the right side of your screen, the abstinence only or that medically supervised withdrawal, you'll see that yes, if there is complete abstinence, that does decrease and eliminate any exposure of opioids to the fetus. However, there is a significantly high rate of relapse that can happen. Depending on what article you're looking at, rates of relapse range anywhere between 56 or 59% to approximately 90% of individuals if they are using abstinence as their method for recovery. So when we are looking at using medications for opioid use like methadone or buprenorphine, this can, in comparison to abstinence, increase the rate of neonatal abstinence syndrome. But we see that it prevents opioid cravings, it prevents withdrawal, and it reduces the rate of opioid overdose. Relapse during pregnancy is high risk during pregnancy because it can expose mothers and the fetus to transmission of things like communicable diseases during potentially high risk sexual or drug behaviors. It can also increase risk of obstetric complications and lead to the actual potential for overdose as well. So because the gold standard for treatment during pregnancy is the use of medications for opioid use, when I was designing my study, I wanted to focus in on the moms that were choosing to use medications for opioid use disorder. So much of the literature that we have on opioid use disorder during pregnancy focuses on a few different things. We see the literature talking about medical management and outcomes, specifically medical management of the mom during pregnancy and medical management of the newborn after delivery. We also see some focus on outcomes, for example, how many individuals or how many newborns develop neonatal abstinence syndrome. What we don't hear in the literature is this understanding of the process by which women using medications for opioid use disorder manage their pregnancy. So the voice of the women themselves is really missing from the literature. So I wanted to take a comprehensive look at the mother and how she is self-managing. So in my recent study, I interviewed 16 mothers who self-identified as being in recovery and using medications for opioid use disorder as their recovery approach. They were recruited through local recovery and treatment clinics, as well as through social media forums between June of 2020 to November of 2021. The mothers were within 12 months of giving birth of their baby and spoke English. So I've presented some of the demographics and characteristics here, but I did have representation of first-time mothers as well as experienced mothers, so individuals that this was their third, maybe fourth baby. They also, on average, at the time when I interviewed them, the average time postpartum was 3.5 months after their birth. Both types of medications, methadone and buprenorphine, were represented in the sample of women I spoke with, and the length of time in which they were using medications for their opioid use disorder, that varied. Some individuals had begun using medications at the time they found out they were pregnant, and I did have a selection of individuals that had been using these medications for over 5 years at the time of their interview. So the type of study that I conducted, the end goal of the study was to look at the interviews, review the data that I was hearing in those interviews, and to develop a theory. And so the results from my research have developed or have resulted in a theory called Pregnancy and Early Parenting in Recovery. And this theory is meant to do more than just describe what I heard them say. It's really meant to help explain kind of what it is that they're doing as well. So I'm going to start by talking a little bit about this centerpiece here where it says growing as a healthy dyad. In labor and delivery, when we're referring to a mother-infant pair, we call them a dyad. And so here, mothers discussed navigating these two concurrent identities, one being a mother and one being a person in recovery. And sometimes those two identities were at odds. The mother spoke of the importance of their medications to their recovery and how important their recovery was to them being successful in being the type of mom that they wanted to be. And yet at the same time, they were grappling with this guilt associated with exposing their babies to the different medications or the medications that they were on for their recovery. Each mother discussed the importance of working to have a healthy baby and to grow in a healthy manner themselves as well. And so there was this sense of this continuous growth, and it was expressed by all mothers. And so that's what's represented here by the center of this idea of growing as a healthy dyad. There was not one specific, I'm going to kind of move from the sun a little bit. There wasn't one specific outcome that every single person identified other than this idea of wanting to have continual growth. Let's see here. Okay, so the quote up there talks a little bit about how one woman was describing that being able to be on the medications allowed them to stop thinking about cravings, stop worrying about what their substance use had done and what it had taken away from them in their life, but it allowed them to really focus on becoming a mom and becoming healthy and moving forward. So the data also identified 6 main processes, or these main methods here, and those are the ones that are listed in red. These main processes that pregnant individuals in recovery are actively engaged in during their pregnancy as well as into that postpartum period. And all of these processes were identified by all of the women that I spoke with, but used to varying degrees. So what I want to do now is kind of just talk a little bit about each of these 6 processes quickly that I learned about through the women that I was interviewing. The first process is this process of maintaining vigilance. Maintaining vigilance referred to the internal work that women were doing to continually survey the status of their recovery and also to monitor their baby's development. So when regarding their own recovery process, women discussed monitoring for and actively working to avoid relapse. This was done by reflecting back on maybe themselves while they were actively using, learning to identify triggers that could lead to use, and recognizing themselves signs of potential relapse. This quote that's listed here demonstrates one woman's recognition of some of the common physiologic and psychological triggers and her learning to avoid those states. So this process of learning what to watch for in themselves. When talking about maintaining vigilance when it came to their newborn, mothers described this constant state of watching for signs of withdrawal in their newborn. And this was specific to that early, immediate postpartum period. But once those initial days and then the initial days postpartum passed, this maintaining vigilance moved beyond watching for those initial signs of withdrawal and moved towards looking for signs of developmental milestones. So for example, they were watching for those first developmental milestones like a social smile, when their baby was going to start responding to their name. And when the baby reached those different milestones in the expected time range where we would expect newborns or the babies to develop, it did reinforce to the women that they were doing a good job as a parent. And it also provided some relief to them because they were still holding on to some of that guilt that the medications they used for their recovery were going to have lifelong impact for their child. The second process that I heard all women talk about was this idea of performing self-care. And performing self-care was this process that they felt was important to meet the holistic needs of the mother and so that the mother and the baby could be healthy together. Some of the examples that women gave were eating healthy, getting exercise, surrounding themselves with supportive people, praying, arts and crafts. And women saw self-care as something foundational, not only to their mothering, but to their recovery as well. The next process that women talked about was something that I called putting in the work of recovery. And this was the process that encompassed all of the learning, the complying with, and the managing all of the aspects of an individual's recovery program. Because the women in the interview were all using medications for opioid use disorder, much of putting in the work meant that they were being involved in all of those daily steps that they needed to follow to be compliant with their treatment and recovery clinics procedures. So balancing the time commitment to complete required group therapy meetings, individual counseling, scheduled and unannounced drug testing, and any other required appointments. For mothers taking methadone, this meant additionally daily visits to the clinic to pick up their methadone. And for one mother, she talked about having a 1-hour round trip that she was driving every day during pregnancy, but then even in that postpartum period. So when she went home at 5 days postpartum with her newborn, that next day she was driving 1-hour round trip to get her methadone. Advocating was another process that I heard all women talk about. This served the dual purpose of building a sense of empowerment for the mother, but also this communicated to others like providers, healthcare providers, that they were capable and that they were prepared. Women felt strongly that they wanted to be involved in the decision-making process when it came to their care, the care of their baby. And commonly mentioned topics of advocacy were things around pain management for the mother while she was laboring and in that postpartum period. Also wanting to be included in the plan of care for the newborn, especially if if their newborn did develop signs of withdrawal. So navigating social capital was another process that all women talked about. Social capital refers to the assistance and the support a person has access to. And as individuals create larger support networks of support, their social capital grows. And so this navigating social capital was the process of identifying and using different sources of support. So this could be assistance, it could be sources of emotional support, but mothers described a variety of different types of support that they needed. They talked about determining who is best at meeting those different types of support that they needed. And they talked about seeking out the individual that was going to best meet their needs at the correct time. So not all women used the same sources of support in the same way, but all women talked about this like support triage strategy that they had to help them meet the needs for themselves and for their newborn. The last process that came up was acquiring new skills and knowledge. Mothers were really devoted to educating themselves about motherhood, about their medications that they were on for their recovery, about those potential impacts that their medications could have on their newborn. And this was intentional work done because women wanted to be seen as active participants. They wanted to feel prepared for birth. They wanted to be prepared for when they were taking their baby home with them. And they wanted to be seen as capable mothers by others around them. So women spoke of engaging in each of these processes to some degree. And you could see that there was differences in how individuals were utilizing these different processes. So one thing that I thought was very important in the findings that I had is that not only were women very actively engaged in using these different processes to meet the needs of themselves and to self-manage themselves and their recovery, but I also found that there were personal as well as social factors that impacted how well they were able to use these different processes or engage in those. And so 2 personal factors, their personal experience with motherhood and how stable they felt that they were in the recovery, impacted to what extent they were able to engage in some of these processes. And then the social factor of stigma or experiencing stigma or even anticipating stigma impacted the way in which they engaged in these processes as well. So the personal experience with motherhood in individuals that had prior experience as a mother, so this is maybe their second or their third child, those individuals were not nearly as focused on day-to-day tasks of learning how to care for a newborn. They were more focused on learning how this addition to their family was going to change the dynamics within that family. The personal factor of their stability in recovery was another way that really impacted the different processes. So stability in recovery took into account not just how long that they had identified themselves as being in recovery, but also the perception of their likelihood to relapse. So in individuals that felt that they were new in recovery or fresh in their recovery, those individuals in general were using earlier stages or less advanced processes than individuals that identified themselves as being more stable in their recovery. If we look more closely at the process of maintaining vigilance, and we think about how the factor of stability and recovery impacts maintaining vigilance, we're able to see that mothers that were newer in their recovery were still learning about common relapse triggers. They were learning to self-monitor for signs of relapse. In comparison, mothers who felt that they were more stable in their recovery had already built into their day-to-day lives ways in which they could maintain vigilance. Some others even sought out jobs working in the area of recovery and felt that working to help others maintain vigilance allowed them to have be more engaged in their own self-monitoring. Another example of how that stability and recovery impacted these processes was if you look at the process of advocating. Individuals that were newer in their recovery oftentimes did not feel capable of advocating for themselves. They wanted to be involved in the conversation, but they didn't really feel comfortable advocating. They often looked to others to get advice or seek mentorship, and oftentimes in the moment were not advocating for themselves. In comparison, individuals that were more stable in their recovery or felt that they were more stable in their recovery were much more willing to advocate for themselves, advocate for their newborns. They were willing to mentor other individuals about things to advocate for. And I even had one mother who talked about how she was advocating for different policy changes at the state and the national level as well. And stigma, the experience of being judged or othered by individuals, was a social modifying factor that impacted the way in which these processes were used. Again, not all women experienced direct stigma or talked about experiencing direct stigma, but they had heard of others that had been stigmatized. And so this fear of experiencing stigma made women feel that they needed to prove themselves, prove their capabilities throughout their pregnancy and postpartum, always wanting others to see them as capable. So the findings from the study also, interestingly, align very closely with self-management and the process of self-management for other chronic illnesses. So this just really reinforced the idea that, again, thinking about opioid use disorder as a chronic condition is very important. So getting back to Janelle, her second birth experience, her subsequent birthing experience was very different. She was still on medications for opioid use disorder when she found out she was pregnant, because in her clinic, they followed moms for a year after they gave birth. And so when she was pregnant, again, within those 12 months, she was still already connected with that clinic. And so she continued on her medications during pregnancy. She continued with her group therapy sessions. She partnered with the recovery team. She partnered with her OB. And when she went into labor this time, she made sure that she drove the 45 minutes to the hospital where her OB was working. And this hospital had a partnership with her recovery clinic. The pain management plan that she had developed with her OB was followed, and she had good pain control with her epidural, and she had great pain control postpartum as well. Her newborn was allowed to room in with her, meaning that the newborn stayed with her at all times in the room. And when nurses came in to assess the baby to see if there were signs of withdrawal in the newborn, nurses listened to the mom about how well the baby was eating. They listened to Janelle about how well the baby was sleeping. And so she left the hospital 5 days later feeling much happier about this birth experience and feeling that her concerns and wishes had been taken seriously by the staff. So in Janelle's first birth experience, we heard some of those challenges that are frequent for moms that are in recovery. And here it was a little bit different. So what things were you able to hear in Janelle's second birth story that you felt were different than her first? And I'm sorry, the sun is just getting the best of me.
Catching it right
feel free
there.
to raise your hand, comment in the chat. What were some of the pieces in her second birth that you felt were different than her first?
Lindsay just says she was met with compassion. I typed in she had a voice.
Yes, decreased stigma. She was respected. There was some advocacy. Yeah, so she was able to utilize some of those. You could hear more of those processes. You could hear more that care was coordinated, that she was working with knowledgeable providers. There was trust in the providers that she was working with as well. And that piece of being able to stay, and yes, bonding with her baby, that piece of being able to stay connected with her baby at all times, which was really important to her, she had in that second birth experience. So some things to just kind of wrap up really quick here. The way addiction is perceived by society, including family, healthcare team, even the government, can have significant implications for how individuals with opioid use disorder are treated. Certain commonly held perspectives, such as perceiving like opioid use disorder as a moral failing, a personal choice, these can all lead to more punitive responses to recovery and to treatment. Despite evidence that we know that addiction is a chronic condition, it has genetic and neurochemical components. And so when we talk about opioid use disorder, it's important for us to always remember that it is a chronic medical condition. And like other chronic medical conditions, self-management is going to be a goal. Women who have chosen medications for opioid use disorder in their recovery as their recovery modality during that postpartum and pregnancy period are doing work that's both invisible and visible to us as observers. So it's really important for us to recognize all of the work that they're doing, the fact that they are active agents, they're not passive in their recovery, and that they're working to self-manage their recovery. So we have this opportunity to partner with them. And by increasing our awareness of how actively engaged moms are that are using medications for their recovery, it'll be, hopefully we'll be able to reduce some of that stigma around pregnancy or recovery in pregnancy. Beyond being engaged, the findings also showed that someone's previous experience with motherhood, so whether or not this was their first baby, or this was their second or maybe third baby, as well as their perception of their stability of being in recovery, that those two pieces also impacted the way in which women would engage in those different processes. So it'll be helpful as we are having points of contact with moms, if there's healthcare providers that are working with moms. It's important to take those pieces of information and recognize that an individualized approach is needed. And so by strengthening each of those processes, or even one of the processes that women engage in, we have the opportunity to enhance their ability to self-manage their recovery and therefore grow as a healthy dyad or a healthy mother-infant pair. So again, it's important to help reduce stigma through giving voice to women. I'm hoping that some of their stories and that their quotes will help to further reduce stigma, because we do see from the literature that stigma is one of the greatest barriers mothers are facing. They have the stigma of opioid use disorder, and it's compounded by the fact that it's during pregnancy. And so the stigma that they experience can impact their access to healthcare. It can impact their outcomes for both mom and baby. And because it is that greatest barrier that they have, by again sharing their stories, I'm hoping to decrease some of that stigma. I just wanted to leave you with this one quote. I always finish my interviews with asking mothers, is there anything else that you think I should know? And one woman stated that it's important that I know that the reason why any mother who's in a treatment program, it's to better their babies and themselves. It's not to switch from one drug to another, it's to better their lives. So again, my hope is that we can kind of keep these words in mind and then slowly chip away at some of that stigma that surrounds recovery in pregnancy. I do have just a couple little key resources, but I also have my contact information here.
Nicole, thank you. And we will send this slide deck out. Questions for Nicole. I'm going to stop sharing so you can all see each other. Any other questions for Nicole? Poor Nicole needs sunglasses.
Twist, and there we go.
There you are. Agree with Mary Simon. Thank you so much for being here.